Cheers. Man, it's been a minute.
It has. We've had some vacations. We've had some things going on to where
Life is life.
Yeah, life is life, and that doesn't give us an excuse to not do our exercises and not do what we should be doing. But
we did not exercise today.
We didn't. You're right,
but that's because we're concerned about my shoulder.
Yes.
Because as a father, I threw my child into his crib as he requested. That's important, as he requested. And yeah, at 31, my shoulder took a bruising for some reason. So
yep, it's nothing that any other patient hasn't probably done themselves,
right.
But at the same time,
it'll tie really well into this episode.
It will.
I think it'll tie really, really well, which is fantastic. So let's see. What was our question of the week this week? Dream and practical car.
Yeah, there's a lot of responses. There's a lot of just random cars. My dream was just a Chevy Silverado, something simple.
You were the Chevy Silverado?
I told you that.
So earlier this week when our patient said, who the hell put Chevy Silverado? You just didn't shine.
Get all the fast cars and stuff like that. That'd be really fun, but I just want something functional. I want something that can house my family, my dogs, go up on, off-roading or something like that.
But is that really a practical car?
I guess maybe not.
You kind of diverted.
That's my dream car. Yeah.
So for me, I went two routes, right? So when I was younger, I was playing this game called Midnight Club Dub Edition, and there was a Lamborghini Murcielago on there. It was like a $900,000 car.
Okay.
So if you're going for price, it's that. But if you're going for like nostalgia feel, it's a 1957 Chevy Bel Air with a blue bottom, white top, or a 2005 red Ford Ranger.
2000, really?
Yeah.
Ford Ranger.
Dude, the Ford Rangers, small trucks, just reliable, just
the three-seater.
It just felt good, yeah. Three-seater just felt good. I don't know, there's something about it. Driving on the back roads of Indiana with it.
See, would you rather have that? Would you rather have like a Ford? I don't know, Ford F-150 from like 1970?
Maybe.
It's got the long extended bed.
Yeah.
I
don't know. It's a tough question. Anyway, so welcome in. Again, it's been a minute.
Yeah.
But we're here. Today's episode, old Auntie Arthur. Auntie Arthritis. The big bad A word that we hear. And today, so we're drinking Bladenbow today. Now, this is a gift from a friend.
Mm-hmm.
And shout out to Ameris. I did not even know about this, right?
Yeah, I mean, it's around.
Yeah.
Where's it from again? I can't remember. It's local.
It's truly local. I do think it is truly local.
Yeah.
But it has a little key on the bottle. It's a cool bottle. And so I was surprised when I drank this, right?
Because it's Louisville.
Oh, Louisville.
Yeah.
Okay, so I'm local.
But it seems more local.
So I was surprised because I took a drink and I was like, yeah, it's not one of the brands you normally hear a ton about.
Yes, exactly.
But this friend that brought this is pretty knowledgeable in terms of alcohol. And so she's like, I really think you're going to like it. And boy, howdy, I loved the hell out of it. I mean, even you've liked it. It's just so smooth and so good. And so, I have my app now, which I love saying because it's hilarious. It's called Only Drams.
Yeah.
Which is just a very fun time. And it's really cool because you can just scan the barcode. It's completely free. I mean, you could sign up for a subscription, which lets you enter giveaways for really expensive bottles of bourbon and whiskey, but it lets you scan the barcode and it gives you what the price point of that is. It keeps your collection together. You can take notes on it. You can say if it's open or closed. It gives you the secondary market value, and then it gives you the rarity of it.
Yeah.
So that is pretty cool. So this is about a $50, $60 bottle, which for some people is still pretty high.
Yeah.
But it's all in all, it's a really good flavor.
Yeah, good flavor. A little strong in intensity, but I think it's pretty good. A little caramely in there.
It's got that caramel. So for me, what's different about this one is normally you get that hit right at the end.
Yeah.
I feel like I get it in the beginning, and then it smooths out the rest of the way, and I get a little bit of that nuttiness. I get a little bit of that caramel. Almost get very orangey flavors at the tail end. So I really like it. And I really want to try this with like smoking it with the topper for the bourbon and doing an old fashioned and smoking it. I think it'd be really, really good.
Absolutely.
All right. So we're gonna get into a little bit of that terrible. I hate seeing it. Overused diagnosis of osteoarthritis. And I say it's terrible because it's overused. Not because it in itself is a bad diagnosis.
Right. No, it's common. It's so common that it can be overused.
Correct.
there's differences between the two. We'll talk about those in a second, but all the time we constantly get patients coming in and says, yeah, my doctor says I have arthritis. X-ray came back, I got some arthritis in there. And so they have that fixated mindset that what their pain is arthritis. And that may well be the case.
Could be.
Or it may not. And that's our job to figure that out.
And here's my problem, right? And this is not just primary care doctors. This is not just MDs. This is the healthcare field in general. Because I do know we kind of rag on MDs a bit. Yeah. But this is the healthcare field in general. When we look at somebody and say arthritis, it's like, oh, sorry, it's just arthritis.
Yeah, it's just arthritis.
And that's the problem. It's PTs too.
Mm-hmm.
It is PTs, it is chiropractors, it is massage therapists, it is OTs. We look at somebody and we go, oh yeah, it's arthritis. There's not really a lot we can do about that.
It's an easy way out.
Yeah, it's the sciatica of bones, right? It's just, oh yeah, it's arthritis. Sorry, you're just going to be in pain for the rest of your life.
Yeah, you're just going to deal with it.
Not only does that affect the mental health of our patients, which we'll get into a chronic pain episode here down the line, but not only does that affect the mental health of our patients, it can change the healing timeline for that diagnosis, and they may just stop seeking help. They may be done. They may just like, I'm going to be in pain for the rest of my life. That sucks. Wow.
Meloxicam is very much one of the go-to medications that patients are going to take for this.
Ibuprofen arthritis.
Ibuprofen, NSAIDs, right?
Yeah.
And they're going to just be stuck on that and just pop that every single day, not really realizing that it could have harmful effects to their stomach, among other things, and they're not going to exercise. They're not going to do the things that they should do because they have arthritis, and there's nothing that they can do about it.
Well, and what is frustrating to me is it doesn't make sense to look at your patient and say, yeah, it's arthritis, I can't do anything about it.
Yeah.
And what that shows me is that you just don't understand the mechanics of arthritis. Because if you understood the mechanics of it, you'd be like, oh yeah, let's get you to a PT.
Mm-hmm. Exactly.
That's so simple. Mm-hmm. That's so much more simple than being like, for me, I would rather say, yep, here's the solution, as opposed to, sorry, you got to live with this for the rest of your life.
Exactly.
Like, that's so weird to me to be able to do that. Mm-hmm. So let's get in. I know that we wanted to talk about the difference between osteoarthritis and rheumatoid, and that is something that I think we can just briefly kind of gloss into. So I'll let you kind of lean into that a little bit more.
Can be brief with it. So when we have osteoarthritis, we have rheumatoid arthritis. Osteoarthritis means literally inflammation of the bone, of the joint. And a lot of times patients will wake up about, in the morning, they'll be really sore, really stiff for only about 30 minutes. Yeah. It's usually on one side. It usually comes with like bony deformities maybe sometimes. And so that's where it's the most common one. So patients will come in with that all the time. It might be in the shoulder, it might be in the opposite foot, it might be in the knee, very common in the knee. And so that's osteoarthritis.
Yeah.
Okay. Rheumatoid arthritis is a little bit more systemic to where you're going to be sore in the morning for about an hour. You're going to be hit in both shoulders, both elbows, both knees, and it might be the entire body.
When it's usually at that joint.
It's actually exactly.
You're gonna get that swelling in there.
You have more noticeable deformities. Like sometimes patients will have their hands like this, or their feet.
Fingers are like that.
Exactly.
The joint will swell up, almost look like a nodule in there.
Exactly.
And it's usually accompanied by a lot more pain.
Yes.
And there are stark differences between how you're going to treat those two things.
Both.
Stark differences. And to be fair with you, we don't encounter a ton of rheumatoid.
No, it's not as common, obviously. Yeah. It varies on when people get diagnosed with it. It's more with women for rheumatoid arthritis. But no, we see primarily osteoarthritis. In fact, probably every other patient has some kind of osteoarthritis in a joint. The question is it the cause of their pain, or is it something else?
Yeah. And now, so this is my explanation of arthritis. And I know that somebody in our comments is going to have a problem with this.
Probably.
And that's okay. I really don't give a shit. Because this is what has helped my patients, and this is what has broken it down for them. When a patient comes into me, the first thing they say is, I've got arthritis. I don't really think there's anything you guys can do about that. And I look at them and say, that's false. That's bullshit. And I say, do you understand arthritis? And not once has anybody looked at me and said, yep. So my response to them is this, and I'm going to set my drink down here first time. My response is this. I'm a hand talker. I got to talk with the hands.
Yeah, me too.
I like to talk about the knee joint. To me, it makes the most sense. That's where a lot of arthritic changes happen, right? Your knee joint is sitting like this, right? And we move all day, every day. And those bones have a space in between them where we have tissue that helps to soften that cushion, which is your meniscus. But then we also, like, our muscles help to give us a little bit of that separation in the joint, right? So when we're young, great, we're happy, we're healthy, we're fine. Our muscles are strong, they can tolerate our body weight, everything like that. As life comes, we stop being as physically active, we get tired. All of a sudden, those muscles aren't helping. We wear away some of that cushion, and now
we're grinding.
We're compressing. And people are like, okay, well, why didn't I get arthritis till I was 40, 50, 60? Great question. Because when you're young, you still have that really good outer layer of bone. And that outer layer of bone doesn't have any nerves. So it doesn't feel anything. If your bone was exposed right now, it's just the outer layer, and I touched it, and you closed your eyes, you wouldn't know, right? You'd be terrified, but you wouldn't know. And so that outer layer for a long period of our lifetime isn't bad because it doesn't have any nerves. Our body's able to keep up with the tear down and rebuild of bones, so we're fine. But as that continues to grind over and over again, and as we get weaker and there's more compression because we see physical activity decrease through the stages of life, there's more and more compression. You start to wear away that top layer of bone. And once you wear away that top layer of bone, you expose the subcortical level. And that second layer, that layer that sits underneath there, has a ton of free nerve endings. And that is now where, oh, now you're grinding in that layer. Oh, but now those nerve endings are there. Boom. There's that dull ache. There's that inflammation. There's that discomfort.
Soreness.
There's that soreness. There it all is, which is why it's so dependent on which positions you move in. And then you think about the crepitus, the creepy, the cracky. Well, of course, the bone's not smooth anymore.
Yeah.
So now you're rocking and moving in between the bones. And so that in itself is what I feel is one of the best explanations to people, because it really helps them understand this isn't just some vague, weird disease. You got weak and your bones grinded on each other. And after a period of time, they got tired of grinding on each other. So now we need to get you strong to pull that apart a little bit.
Exactly.
Right? And that is where the PT comes into play. That is a big portion of where the PT comes into play.
And how many times have we noticed patients that come in with arthritic symptoms, you know, they're saying they have arthritis, and then you watch them squat. It's like
terrible.
Their knees go forward. They're not using any of their hip.
We have to do a squat on like show good squat.
Oh, for sure.
Which we'll get flack for too, because there's 1,000 ways to do a squat, but from the PT side of it, there is a way to just take pressure off your knees.
Exactly.
And that's the focus that we would be putting on. So we'll talk about that.
So in addition to your strength of your muscles, are you doing the squat right? Are you moving right? You could be the strongest person in the world. If you're not moving right, you're going to cause stuff at the joint.
Yeah, what do your mechanics look like?
Exactly.
What is this? And so we have a lot to talk about. We just don't necessarily have the time to talk about it today. So this may be stuff that we touch on moving forward. But what really grinds my gears into this world is that our patients will come in and say, I've got arthritis, especially in the knees. I need a knee replacement. I need a knee replacement. And so many times have I said, do you? Do you? We have one guy, and I probably talked about him on here before. He's just a great case of this. He's a large man, right? Matt is a big guy, but he's big in terms of muscle. He is a little fat, of course, but he's a big guy in terms of muscle. He's one of those people who are like, that's genetics. And, when I first met him almost a year and a half ago, he could barely walk for 5 seconds. He couldn't put weight on his left leg for 5 seconds. And he's like, yep, doctor wants a knee replacement like within the next 2 weeks. And he said, I don't really think there's anything you can do about it, but if you can just give me some relief over the course of the next 2 weeks. I was like, okay, bet. So I start feeling around. I'm like, hey, I don't know if you know this, but it's not really your joint. He's like, what do you mean? I said, all of your tenderness and inflammation and pain is coming from the muscles that surround your joint. He's like, no way. You're joking. And so we started doing rehab on that. We pushed his knee replacement back literally almost a year and a half. Or almost a year. It was incredible. And the reason, now that he did still have to get it, why? Because this man did some crazy Olympic weightlifting back in the day and absolutely just shredded his joints. So there were secondary causes.
Exactly.
But we postponed a knee replacement by almost a year with just exercise and soft tissue work.
And not only that, you got him more prepared to face the actual surgery. And now he's walking. He's got 140 degrees.
He's 150.
Yeah, 150.
Don't let the therapist tell you to stop at 120 degrees of knee flexion post-op knee replacement. That just
keep going.
Here's my soapbox. It's stupid. Your knee can go 150 degrees. If somebody looks at you, your doctor, your therapist, your PA, whatever, and says, "Oh, you have 125 degrees. That's fine. 120 degrees, you're good." No, shut up. Tell them they're wrong.
Keep going.
Tell them they're wrong. Keep going. But you're right. Let me get off my soapbox. Fuck. But you're right. He was, right? And this is a guy who a post-op knee replacement can be painful. can be painful because moving into knee flexion is pain. I've made Green Berets cry. I've made, you know, NFL, NBA, NHL athletes cry because it is painful.
It's also more painful for men.
It is more painful.
Sure.
Women's pain tolerance is out of this world. Like, I really, truly, it's unbelievable.
It's weird.
It's so funny when men think they're stronger than women. Like, maybe in your muscles, but not in your pride or your ego or anything else. But you know, it can be somewhere between an 8 to 12 to 16 week rehab, depending. And Matt was walking without any assisted device with great knee flexion within like 2 weeks of his surgery because we did so much prehab on it and we worked so hard with dry needling, cupping, soft tissue work, great exercise tolerance and endurance. And that wasn't just strength, it was also aerobic work. It was positional muscle activation. It was all of those things, which were so unbelievably important, right? And so it's those moments where PT can come into play and say, hey, you don't need to get this major surgery. Hey, you don't need to live with pain for the rest of your life. And that's going to segue us into the next question that I always get. What do you think? It feels like arthritis. Do you think I should just get an x-ray? And what do you say?
X-rays, they're going to find some arthritis on there if there is any, right? You know, you can probably look at my knee right now at me at 30 years old, and you probably might find some. I've had 3 surgeries. I've had, you know, a lot of soccer.
Your knees are kind of fucked up.
I've had a lot of,
I'm sorry.
I've been able to rehab.
I'm working on it, but that knee is not in a great place.
I know, it's not. I mean, there's multiple reasons for it, you know, but X-rays, they're not always necessary. The reason it would be indicated is if you had some kind of trauma, some kind of fall, something that possibly caused a fracture. Now, if you are, you know, perfectly healthy at 40 years old and you have knee pain, you probably don't need an x-ray. Correct. If you have pain, it's most likely due to the factors that you just described, mechanical factors, muscle imbalances.
Oh, muscle imbalances are huge.
Tight muscles, stiff muscles, you know, everything. So x-rays, you don't need one unless you had trauma.
And a lot of times in x-ray, and we've talked about x-rays versus MRIs in one of our prior episodes, but a lot of times the x-ray isn't really going to show you much, that it's going to change our treatment. Our treatment is going to be relatively the same.
Insurance wants that x-ray first because they don't want to pay for an MRI. It sucks. It's a waste of time, sometimes a waste of money. But if you really want to, you got to go through the process.
And shout out to our chiros, because sometimes you can just go to a chiropractor, they'll give you x-ray.
True.
And it costs you way less and be way faster. So shout out to the chiros. Y'all doing something right there. But hopefully one day PTs will be able to do that.
Yes.
We're working towards that. Some states have it. We're working towards it.
Exactly.
But, you know, and that really ties well into the treatment plan. So let's say you just come in with osteoarthritis. What am I going to do?
You're going to look at your squat. You're going to look at muscle imbalances. You're going to look at range of motion. You're going to look at other things that it may or may not be, like, is there a nerve involved? Is there...
like some nerve entrapment, like is the nerve stuck in muscle tissue or something like that, which can create numbness and tingling.
Exactly. Like we're going to look at all those things, rule stuff out, and make sure, okay, this is the problem, and then we're going to go after it.
Yeah, because you want to make sure. I mean, again, osteoarthritis is a very vague, very, very encompassing diagnosis. So let's make sure there's nothing else going on, right? And one of the things, like for me, my treatment starts with muscle activation, right? And there was a guy this morning, that Morgan, our new therapist, love her, she's been doing great. But Morgan was treating a guy this morning, and this is a guy who has worked out religiously his entire life and works out every day. And he's like, man, I lift, I do this, I do this, I do this. I said, okay, engage this muscle. He's like, what do you mean?
I'm like, how do I do that?
Engage this muscle. He said, am I engaging it? I was like, no. Yesterday afternoon, D1 star college soccer player, right? Has played soccer her entire life, D1 athlete, training in the weight room every single day. And I laid her on the table, I said, engage your lower core. She said, what? And she sucked in her gut. And she said, I'm engaging again. No, you're not. You're just sucking in your diaphragm. So that muscle activation piece is huge because that's a great start. It doesn't matter if you've been working out 90 years. It doesn't matter if you're working out for 20 minutes. Do you know what muscle to engage? Do you know where the muscle is? And do you know how to activate it? And that's the starting spot. And so from there, then you're right. We're gonna work on that strength. We're gonna work on positional movements. The squat is a great example. Stepping up and stepping down. right?
Yeah.
Standing on one leg. How many times have I pulled people in there who are 8 times my size and I can't get them to stand on one leg?
Every day.
And I show them,
You can do it.
like I always do it the same way. I'm like, okay, stand on your right leg. Now stand on your left leg. I'm like, okay, fine. What am I doing? This is easy.
Yeah.
And then I say, okay, now I'm not going to let you compensate. And they physically will, like, they're so frustrated because I can't get that other foot off the ground because they're so used to tilting their body weight away and not sitting there and being able to stabilize in that leg. And that's a huge problem. So for those of you out there, try it. Stand on one leg without shifting your body weight. Just try it and see if you can do it, because it is hard and it's so basic. But it's those basic things that we've built our entire careers around, and is why patients come to us and say, why is this so different than any other PT I've ever been to? Because I'm helping you understand your body, and I'm not trying to give you a bunch of funky, crazy exercises that may or may not help you in the process.
We're trying to change their life and their outlook of how they use their body, not just, hey, we're just trying to get your knee better and that's it.
Because I don't want to target just the impairments. I don't want to target your I mean, I do want to target the impairments. Well, I don't want to target.
We want to start there, right?
Yeah,
I want to start at this.
Yeah,
we want to start at the symptoms, and then we want to slowly work our way to the direct cause of why they have knee pain.
Correct.
Is it their hip? Is it their foot? Is it truly their knee and the strength? Or is it something else?
Damn, this is good.
Yeah, it's good.
Like, I don't want to drink the whole thing too fast. I'm like, man, this is really, really good. Got some weather out there. But you're right. We do want to do that. And so let's talk about who's at most risk.
Right. It's our patients that are age 50 or greater.
And why? We just talked about that.
Because
physical activity declines, wear and tear.
Exactly. Our muscles do truly get weaker as we age. That's a normal fact of aging. So as you age, the more likely you're going to have joint pain. Women are more apt to arthritis than men. If you're African American, you're more likely to have arthritis. Those are the big three right there. It's just those things can really truly make you more at risk. So and more surgeries.
And we've all said it, right? We've all said it. Or well, we've all heard patients say it. We've all heard people say, "Oh yeah, it's just my knee. It's bone on bone." Maybe. It's like bone on bone. Maybe there is no joint space.
And let's put that out there too. It's like we can't disregard that it very well could be.
It absolutely could be.
And it has happened.
It's a very real diagnosis.
I've had, I can think of 2 patients off the top of my head that have had arthritis at their knees. And, one patient in particular, I got her down from a 7 to a 2. Yeah. And there was a lot of crepitus going on at both knees. There was a lot of other things. And so it really probably was bone on bone and she needed a total knee replacement.
Correct.
But we look at the other things first before we're just ready to say it's bone on bone.
Well, and here's the other portion of it that is really, really important, right? Matt was bone on bone.
Yeah.
And there was nothing I could do to change his bone on bone. So we did have to get a knee replacement. However, we did improve his quality of life long enough, because that's what people ask me. When do I get the knee replacement?
Right.
When do I get the shoulder replacement? When do I get the ankle, foot, whatever, yada, yada, so on and so forth? And I say, when your quality of life is suffering because of your pain and your discomfort. So if it's not suffering, don't do it, right? And if you can tolerate it and go talk to your physical therapist about it, right? Because we can help it. We can do something about it. And I think that that's what's important, because 70% I think this is a fun fact that you found, but I mean, according to the Global Health Agency, 70% of people report joint pain.
Exactly. Yeah. In their older age. Yeah. I think that, one particular website said that, but 30% of patients actually had arthritis as the symptom of joint pain.
Right.
So we're all going to have joint pain at some point, if we haven't already at this age, but is it the cause of our arthritis or is it something else?
Right. And again, this goes back to one of these really basic concepts that you and I have talked about a lot, which feels basic to us and may not be basic for everybody else.
Right.
You need to understand your body.
Yes.
Because that is how you and I treat. And we say it day in and we say it day out. A proactive approach is what we need to be gearing our healthcare system towards, because that is what is truly going to give us longevity, not the reactivity that we have of, ow, it hurts, time to go see somebody.
Yes.
No, it's, ow, it hurts, time to go see somebody. Okay, you did great. Now, what else can we work on for you?
What else can we prevent?
Correct. What else can we do to help you? And I'm not telling you to come see me for the rest of your life. I'm not saying that. I'm saying, what bothers you? Okay, great. Let's fix this, this, and this. Now, in a couple months, come check back in with me. Let's see what else bothers you. Right? And our healthcare system is working towards gearing towards that. But arthritis is one of those things that you do not have to. And God, I feel like we say this on every episode. It is wild to me how many times this comes out of my mouth and it's just still not heard. Right? You do not have to live in pain forever. And just because you need to be critical of your healthcare, just because somebody with a fancy degree, love y'all MDs, PAs, in peace. Just because somebody with a fancy degree looks at you and says, it's this, you're going to be in pain for the rest of your life. You don't just say, yep, you're right. Walk away.
Let me take meloxicam.
Let me take meloxicam. Let me just deal with the pain for the rest. No. Be critical. Find different avenues. Look at different pathways.
Ask more questions.
Ask more questions. My son is in the but why phase. But why? But why? But why? And I love that because that's what I do. And sometimes it pisses people off. It's pissed you off.
Yeah.
You'll be saying something, I'll be like, but why? And you'll go, well, this isn't, okay, why? And this isn't, but why? And you're just like, what do you mean, but why? And it's because I'm trying to get to the root of that base of knowledge, right? I'm trying to understand where that's coming from, and I'm not just accepting platitudes as fact, right?
Right.
Oh, well, this is just the way it is. But why?
But why?
Why? Well, that's just how the medical system works. But why? Right? And it does drives my students crazy. Every time I have a student, it pisses them off to no end because it's how I test the depth of your knowledge.
Yeah.
Like, are you just accepting what people tell you, or do you fundamentally understand it?
Exactly.
And that's what we need to do, is we need to fundamentally understand our bodies. In a lot of ways, it's helping me fundamentally understand it, right? If I'm probing the depths of your knowledge, it's because I don't maybe know. So I want to know. That, like, my whole goal in life is to learn as much as physically possible. So let me understand it. It should be, but we don't. But let me understand the depths of it. And that's what these patients should be doing when it comes to arthritis, because it is not a lifelong diagnosis that is just going to mean you're in pain for the rest of your life. It's not an old person's disease. It's not, I mean, my favorite study, have we talked about this? Have we talked about the study with the x-ray? Maybe we did in our x-ray slides.
Yeah.
But just as a recap, one of my favorite studies is you had this big auditorium of people. It was a symposium of people, probably 1,000 plus, and they put 2 x-rays on the screen.
Oh, we have talked about this.
Yeah, I thought we did.
Yeah.
They put 2 x-rays on the screen, and one of them looked horrific. It was of the spine, and it was, arthritic changes, lack of joint space, bone spurs, degenerative disc, slipped disc, broken disc, what the fuck ever you want to call it. And the other one was super clean, and they said, who has pain? Clean one. And obviously everybody said the one that looked like trash. And they were like, no, this is like a 98-year-old female who runs CrossFit and does triathlons and is in the best shape of her life. The clean one is a 21-year-old student with low back pain that was diagnosed with arthritis and DJD, which is degenerative disc disease. So it doesn't matter what age you are. And it truthfully, at the end of the day, it may not matter what that imaging says. And it may not matter what that doctor says. It may not matter what I say. What matters is you getting better, right? And I even tell that to patients all the time. I'm like, listen, just because I say it doesn't mean it's true either. You have to be critical of everything I say. And I tell patients all the time, you've heard me say this, challenge me. I've heard you say it.
Yeah.
Challenge me. Ask those questions, because everybody's like, oh, I'm so sorry. I'm like, stop. No, don't apologize.
Please ask more.
Fuck that. Ask more. Ask me what you want to know, because I want to share this knowledge.
In that 45 minutes plus that we have with patients, they pay us to give our knowledge. That's why they come see us, is that they don't know anything about their bodies or what the pain is, or what they can do to help it. They're there to
I've had people who come in, and for their entire 45 minutes, we dive into their diagnosis.
Mm-hmm.
We open the books. We look at the research. We look at the anatomy. I show them the pictures of everything. I explain to them step by step by step by step, right? Just because I have this knowledge doesn't mean I shouldn't disseminate it with the people that are around me, so that they also have that knowledge and they can understand. Because guess what? They're going to pass it to the next, and to the next, and to the next. And that is how you create a change in the world.
Amen.
Man, what a great episode. I'm just so fired up about this, man.
Amen.
I just get so fucking fired up about this, because PTs do it. It just grinds my gears, right? Don't look at somebody and say, sorry, you're screwed with pain the rest of your life. You are their hope.
Yeah.
You are their hope.
Yeah.
Be their fucking hope. And if you can't fix their pain, help them manage it. Exactly. Do something about it. Don't just be like, sorry, you got arthritis, I can't do anything about it. Whoopsie daisy. And that's
send them to somebody who can. Do more for them.
Everybody on here must be like, what is this?
Be their advocate. I mean, that's what they tell us in PT school, is like, be the patient's advocate, because they may not advocate for themselves as they should. Mm-hmm. Their physician may not. Mm-hmm. Their caregiver may not, depending on the patient. So be the advocate. Try and get some help if you can't solve it, because they don't deserve to be in pain.
Well, we're working through the therapeutic alliance, right? And that's hard. And what that is inherently is that everybody that is of a medical staff, and maybe some people that aren't medical, but are helping you with what you're going through, we all need to be communicating with each other. And right now, between insurances and all the varying EMRs and all the varying systems, it's hard to do that, right? And the fact that in 2025 we're still using a fucking fax machine is crazy.
Well, the fact in 2025 I still have to call a physician's office and get their answering machine, among other things, and it takes sometimes days for me to receive it back. Is also really
yeah. And so those are the struggles and those are the realizations. But your therapeutic alliance are the group of people around you that need to be helping you guide you on your journey and in communicating with each other to say, oh, I don't know this answer. Let's call your doctor and let's find out.
Right.
I don't know this answer. Let's call your chiropractor or your physical therapist and figure this out. I don't know that answer. Let's call your OT or your massage therapist and figure out. Because I have no problems communicating with anybody in the healthcare field. I'll talk to trainers. I'll talk to coaches. I'll talk to anybody. And I will communicate with you my thoughts and I will be receptive to your thoughts. And that's the piece that's missing is the receptivity and the growth of being able to say, oh, yeah, you know what? That actually might not be a bad idea. Let me look into that instead of being stuck in your ways.
Exactly.
And that's the stuff that's going to help our patients move forward and how they can grow and learn to live without pain. And if every patient had their own little therapeutic alliance, holy shit, we'd be operating so efficiently.
Amen.
People would be without pain for the most part. We'd be doing really, really good at our jobs, but our system would just run so much better. That's what's crazy. But you know what? We're two guys sitting here getting old. You're about to hit 31 here soon. And
you're 31.
I'm 31 now. And so just wait. You turn 31 and maybe you'll hit us
2 months.
Labral tear or rotator cuff tear, whatever's going on my shoulder. I just need you to fix it. That's all I need you to do.
You got a bunch of trigger points, some decreased space in your joint capsule. You need to rest it.
Listen, you fix this shoulder and maybe I'll eat some brownies. How about that? I don't like chocolate chip cookies and I don't like brownies and and I know that's slack. I don't love a lot of chocolate.
You don't like chocolate.
Chocolate is a secondary flavor. It needs to be combined with other things. People in the comments can fight me on that.
Please, somebody fight him because I want to.
You know what the best thing is? Oatmeal raisin.
100% false.
That's exactly the truth.
We put a poll out there.
Oatmeal raisin cookies are good every single time.
No.
100% of the time.
Anything with raisins in it is down here.
The overarching messages. I know some of the people that are out there that are listening to this right now are thinking, I've got arthritis. What do I do? So send us a message or go talk to your physical therapist. And if your physical therapist looks at you and says, I can't do anything about arthritis, find a different one. Find a new one. If they're not putting their hands on you or dry needling you or working on your squat form.
If they're just throwing exercises.
If they're just throwing random stretches at you.
Yeah, especially stretches.
Find a new one.
Yeah.
Talk to your doctors. Ask them for referrals if you feel like you need one, if your insurance requires one. Don't sit there and live with the discomfort and the pain just because somebody tells you that that's what you have to do. Don't do that. Find the help that you need. Talk to the right people and don't stop until you get the right answer.
Amen.
Great episode, bud. Wonderful. Cheers. All right. That was fast enough for you?
No, that was perfect.
I didn't think it was bad.
No.
I mean, we definitely zoomed. It was